Presentation is not my work. It's actually the work of entire tuberculosis program in Georgia, starting very early. I have contributed to this work in years of 2004, 2010. I was actually the drug-resistant TB program manager, introduced drug-resistant TB diagnostics and treatment, and we reached universal access in 3 years. So I'm allowing myself to present this data, focusing on the drug resistance TB management. My co-author here is my PhD student, Maya Kipiani, who now kind of works in National TB Program, and she's the Deputy Director of Research Department. This is just a presentation of the TB notification data from 2010, and you definitely see that the work conducted by the National TB Program has shown some success. We have decreased both in notification and in estimated incidence rates, although there are still remaining gaps showing underdetection of TB cases at some level, and National TB Program should work on improving this gap, and implementation research in that direction could also be the way to collaborate in the future. As I said, my presentation focuses on drug-resistant TB management, and this is the surveillance data focusing on MDR-TB treatment outcomes, starting in 2009 through 2021. And I don't know how to pointer we have here. Okay, you can see like yellow color shows the loss to follow-up, and you see that pretty high loss to follow-up proportions in early years, which gradually decreases, steadily decreases from 2009 to 2021. You also see the increase in treatment success rates and decrease in treatment failure rates. This is not all TB program. As you know, there have been the great breakthrough in the development of new drugs and regimens that led to the increase in treatment success of MDR-TB. This is to actually show the gap, initial gap, and the improvement or what has been reached. In 2010, treatment success rate among MDR-TB patients was 54%, and in 2021, the success rate reached 76%. Huge improvement. What led to this improvement? In Georgia, introduction of the second-line TB treatment, where I actually contributed, started in 2008, and we reached universal access in 2011. In 2014, there was the introduction of bedaquiline as for palliative use for the chronic patients only. In 2015, U.S. Embassy donation of 150 bedaquiline courses, 15-17 NICS TB trial, 17-21 Xenix trial, STREAM study in parallel, and also the MSTR pragmatic trials. These are the trials that actually created evidence about the efficacy of the new drugs and regimens. And the goal, implementation goal, was to translate this trial evidence into routine practice. Implementation challenges specific to Georgia was we kind of classified them in three levels, more multi-level. Patient level is the patient safety monitoring, treatment adherence, provider level, provider capacity building in implementation new drugs and regimens, and system level is access to new drugs and diagnostics. Implementation framework I'm proposing here is the RE-AIM framework, which has 5 domains. REACH is the percent of eligible patients receiving new regimens, effectiveness, treatment success rate, adaptation, uptake of new guidelines and protocols, implementation, which is fidelity, training, guidance, guideline adherence, maintenance, it's a sustainability and continued use. Implementation strategy, as was instructed by the template, is I mapped the domains of the implementation framework, then implementation outcome, and the ERIC implementation strategy to reach eligible patients, to increase the percentage of patients who are eligible for drug-resistant TB treatment. There is a need to implement or strengthen the diagnostics of drug-resistant TB. So the strategy was to increase access to diagnostics to molecular WHO recommended rapid diagnostic tests, expert MTB-REF and expert XDR, effectiveness in the percent of treatment success, and monitors outcomes. That was a strategy and supervision. And the monitoring was conducted through the established electronic TB surveillance system. Then adaptation, uptake of new protocols. I just showed the slide of clinical trials that have been conducted in Georgia. This clinic also, as one of the sites, was Georgia, because it's a multi-country clinical trials, and WHO has used them to update the drug-resistant TB treatment guidelines. And then these guidelines came back to Georgia again, and we adapted them, or National TB Program adapted them and updated the national guidelines. And the TB expert committee has been established and is responsible for those updates. Implementation fidelities, this is annual trainings, which give a continuous medical education credit. Audit and feedback was used. It's a monthly supervision visits, quarterly supervision meetings where the feedback is provided, and also national and international DRTB Consilium. Consilium is kind of Soviet word. It's actually committee of people, experts in TB management, clinical management, which meet quarterly, monthly, and provide feedback to the TB doctors at regional district facility levels. Maintenance, sustainability, and continued use of these new regimens is the National Strategic Plan has been developed, updated throughout those years. State funding has been secured, and the global funding has also been secured. Implementation outcomes, colleagues, Rick and Luke have advised to just focus on one example of implementation outcome. Why I'm going back and forth, I don't know. Anyways, I'm focusing on the implementation domain, which actually addresses the fidelity and how this was achieved. National DRTB Consilium was created, as I said, in 2008, right when there was an introduction of drug-resistant TB treatment. This was a weekly consilium and is still ongoing, 52 per year. Meetings, total of 884 meetings have been conducted and have provided feedback to the doctors at the regional and district levels. Maintains fidelity throughout expert oversight. That's a linked implementation outcome. Then WHO Europe supports DRTB treatment through virtual medical consiliums. This has established in 2020. It's a monthly consilium meeting. So far, 55 consilium meetings has been conducted, and implementation outcome is shared decision-making support guideline adherence. And annual trainings are being conducted in the National TB Program since 1999, actually. These are the five-day annual trainings. The coverage is 100%, no matter how weird it sounds, it is 100%, 154 TB doctors we have registered, and we provide them the training, 5-day training, and guideline updates, which has been done into recent updates in 2020, 2022, 2024, have been kind of provided the trainings on those updates to those TB doctors. This is a short kind of overview of MDR-TB management with the lens of implementation science, and questions for discussion for the audience. And these are the questions. Should I continue facilitation, or you help me? I would appreciate any help if there is. Yeah.
Yeah. Would you like me to, or how we should proceed?
I think that the way that.
Wait a moment.
So if we think about where we were a little bit earlier, we were with people who were starting their PhD, and now this is really sort of a work in progress. And one of the questions that was asked during the earlier sessions is, can you sort of do implementation science without sort of actively doing things? And one of the things that I think that we're seeing here is the implementation rollout and helping to understand and potentially sort of explain. And I would at least say from my perspective, and we'll get to some of these questions, is I always ask the question, what now? right? So you've gotten this, you basically have done a number of implementation strategies for whatever we're looking over this time period, and we've got it to sort of diving down. And so one of the questions would be that you would ask is, you've got your data, what now? So I would say that's it. And then you have a series of, questions, and maybe if somebody wants to comment on what they think the next, sort of thing is to do, but it sort of has a number of things about which re-aim domains can we realistically assess, with the, available surveillance data. It's, one of the key things is the better your data are, the better you're able to sort of assess, kind of what you're doing, and are you getting the number of cases? And so, one of the things that I would say, are you reaching all the people? But has MDR, for instance, or XDR, either one of those, have those numbers been reducing in parallel?
Yes.
And are they reducing at the same time? Because it may mean that you're attacking both things at once. And if you saw curves diverge where one of them was a little bit more flat, the slope was not, you would think maybe to sort of really focus on, some of those, sorts of issues. And then, of course, the other thing that's always an issue in TB, and of course, I'm a little embarrassed to do this because we've got sort of a world TB expert, here, but if your surveillance data is showing this, do we have a detection problem, right? And so are things not being detected, people are dying, and other sorts of things. So you could ask that. You probably have a number of ways to sort of monitoring that, people dying of unknown cause and stuff like that. And then in terms of, the re-aim domains, I mean, when you showed, go back to your original sort of slide with the block graphs where you show some of the gaps there, they'd actually get right there. Go back one more, yeah. So, one of the things right here is you've got this loss to follow-up, and you've got, looks like maybe something like 25% in 2009, and you sort of have reduced that gap to probably less than 10%.
Exactly. Yeah.
And so you've done a really good job. So you could ask the question: are any of these sort of changing? The failed number has gone down to almost nothing. It's 1 or 2%. I can't tell the color, but the death rate is interesting. The death rate hasn't changed.
Yeah.
I mean, I think looking across all that, so I would say, is there a place where you could certainly reduce that? And one of the questions I would ask is that because they're being diagnosed too late? And then that becomes a detection issue, right? And so, when you're sort of thinking about the ones that you, sort of looked at, doesn't seem like a lot of the adoption things may be sort of a problem. Are you able to measure that?
No, not really. I don't have that measurement at this moment, but we could think of formally kind of creating some kind of tool.
Yeah, I think so, there's that. And then I would say that the one thing that still stands out to me is that, people are still dying of tuberculosis when,
yeah. It can be also the chronic cases. It can be the poor management of comorbidities. I'm just speculating here, Rick, because I didn't look into the data deeply, but the speculation.
But that becomes an implementation question,
Absolutely.
right?
I can frame several implementation questions like the comorbidity management, like late diagnosis. Adherence has improved because loss to follow-up has decreased, but are there like primary loss to follow-ups which kind of didn't even start the treatment? And as per the WHO surveillance systems, these primary loss to follow-ups, or primary so-called defaulters, were not included initially in the routine surveillance, but they have modified the surveillance guidelines, and now they are also included. So we can monitor them in the future. But there are also lots of other data available through WHO site, which is reported by the National TB Program. For the sake of time, I didn't present them there, but we can go deep into that if we would like to.
So, so I think the questions are, one is, what are the things that you're not impacting? And it's data.
Yes.
And, it's not a big percentage, but this is a completely treatable, disease.
Yes.
So you get at the question, is it because they've got some kind of immunocompromise like HIV or something like that? Yes. It's not a high burden country, but that is one of the big contributors, at least worldwide. And if that's the case, one of the things that we heard about yesterday that's a real issue, at least for preventive therapy, is that, there's no TB treatment or preventive therapy at the AIDS center. And so one of the potential solutions is an integration type of model.
Yes.
In terms of, one, doing some of the prevention, because your case rate will go down if you're also able to prevent better. And I suspect, and I understand that there's not that good of prevention. So, this is a country that's one of the places where it's really heading towards elimination, right?
Exactly.
And so, to get into that sort of that last pillar is the place where there's not been success. So I would say that's the next generation. And I know that there's some thinking about that. And then go to your next slide, that one. No, go back. Yeah. And so the question is, the curve is going like this, and are you able to do anything to bend the curve even a little bit further? So in other words, if this becomes what I call an interrupted time series at this point, and everything is added on. And so, to sort of think about whether there's something that you can do to bend the curve that's beyond just the sort of the natural rate of sort of dropping down. And that will be just a few of my sort of comments from, sort of looking at the data. You can go back to your questions.
Thank you very much.
But really, the TB expert's the person who has got a lot of the good questions and answers, I think.
Thank you, Luke. I was just going to add to that. When you go back to the slide Rick likes so well with the colors, I always love the data slides, right? One thing that you can do, and you just mentioned that you have a lot more data, one potential here is to really look at who these people are, right? It's not just what their comorbid medical conditions might be, but is it women who are dying more than men? Is it people of older age, younger age, that sort of thing, right? And I would do that with the treatment successes as well as in each of those categories, because what that teaches you is that perhaps the intended recipient of any intervention, it may not be who you think it is. These may not be the same persons across this bar, right? And if they're not, then the strategy for really reaching them, both in terms of potential prevention, but also in terms of intervention, is perhaps different. So characterizing the sample is always something that I think is very useful. And it's a great piece of work for like a master's level student or a PhD level student, right? I mean, it's just to really look at this data under your supervision.
Thank you very much. Thanks.
So other questions for VERIKO?
Thank you. Going back to your last slide with potential questions and to re-aim domains, right? That was your few, yeah. Which re-aim domains? You described this fidelity and actually strategies that have been implemented to increase the fidelity, right? But my question is, if we look at the fidelity from the point of view of, are we measuring it actually when the programs are implemented in a real life, real setting? So are there any opportunities or systems that monitor fidelity, which is simply put adherence to prescribed protocol for TB treatment in this case? And do you think that level of fidelity can actually contribute to clinical outcomes that you showed?
Okay. Can you repeat the last sentence, Dato? Level of fidelity, what about it?
Can contribute to
the
degree of, not level, degree of fidelity can contribute to the clinical outcomes that you showed.
Thank you very much. Thanks. So actually, this slide actually I just created after consultation with Luke. I called the National TB Center to count actually about make the count actual process indicators. So yes, there is a system implemented, which is a supervisory system. 3 trained staff goes on a monthly basis from the central level to the regional level and checks randomly the patient cards and assesses whether the treatment follows actually the national guidelines which have been adopted. Also, this supervisory team, which does this monthly visits, so the national level does the monthly, quarterly visit at the regional level, and then regional level coordinators do the monthly visit at the district, so-called facility level. And in their checklist, there is a check for the fidelity as well, by checking the patient cards and adherence to the treatment regimen itself, and how the safety monitoring is done. So that's the thing, but that is the treatment side. But as we said, this might be caused because of the late diagnosis. So we don't know what the time from the symptom to the diagnosis, and should there be any strategy to raise the awareness of the community, or to involve the community leaders to kind of raise awareness about the TB symptoms and timely access to the TB care. I don't know if there is a need for that at this stage. Initially, when this program was starting, there was a lot of big campaign about awareness campaign, used the mass media, TV, and commercials also about TB symptoms and free treatment, and the TB is curable. This was 20 years ago. I don't know, maybe there is still time to reintroduce such kind of campaign, because things like we forget things. So that could be another way. Did I answer your question? Yeah.
The last question was about if you believe that the quality of care, which is monitored systematically, as I understand, also plays some role in outcomes.
Absolutely, it's the quality of care, and it's I don't know if it's too ambitious statement, but I could say it's also the drugs, like new regimens. They are really effective. So that's basically, and they are short, 3 drugs, lesser adverse events, especially after the linezolid dose reduction. So drugs are there, drugs are free of charge, they are provided to the patients. So it does really improve the outcome. I have seen that, yeah. Not observed here in Georgia, but in multiple other countries as well.
Yeah, Debbie's question, I think, is a good one. You know, the REAIM framework is a very popular one, and it maps very closely with the way we think about HIV cascades, and I think that's been adopted in hepatitis C and TB and other fields. So it is very natural, I think, for even people that don't have a background in implementation science to use. When they did a systematic review of the use of REAIM about 10 years after it was introduced, or actually 20 years after, one of the things that they identified was that a lot of it was using it retrospectively and encouraging people to use it prospectively. So my question for you would be, you know, having gone through this exercise, which is very powerful, of trying to think, okay, how can you backfit it? If we're looking at what are the new regimens, new diagnostics, you know, whole genome sequencing, next generation targeting next generation sequencing, whatever it is, can you think, are there things that realistically could allow us to make these measures in a routine setting, given the resources that are available to the National TB Program to get regular information prospectively on these REAIM type categories?
Well, I think there is. Let's just, can we go specifically to some of the domains, and I can think out loud with you all how this can be obtained, the information about that. First of all, just to start about the % eligible patients receiving the new regimens. Just observing the Luke conducted nominal, Rick conducted nominal group technique yesterday, we could do the same thing among patients and families, even in the community, or among healthcare workers who are actually responsible for the screening and diagnosis, primary healthcare staff maybe, and identify potential barriers and facilitators for the people who with the TB symptoms or suggestive TB symptoms have access, timely access to the healthcare and diagnostics of drug-resistant TB. That could be the one way, and we can do it in a prospective manner, if you agree with me. I'm just, again, speculating here. Now, regarding the treatment effectiveness, the surveillance system, which surveillance system is already available in the country, to my knowledge, it's pretty robust at this moment. I can say that I also contributed to the development of this surveillance system. It has improved a lot since I worked in the TB center. And now it's becoming part of the electronic health records of the state, like it will be integrated. But I think it's pretty robust, pretty detailed, and collects not the information, only outcomes, but also treatment deterrence, like how many doses have been missed, has regimen been changed, number of missed doses, number of hospitalizations, what kind of adverse event reporting even is integrated there. So therefore, I can say that effectiveness is measured pretty well, both retrospectively and prospectively. So that's about effectiveness. About the adaptation and uptake, they are now even in the process of update of TB guidelines, and they have group of experts who help them in the national TB guideline update. So prospectively, probably desk review of those guidelines and to just see whether they are aligned with the international recommendations, the latest recommendations of WHO. That could be the way to measure the adaptation, and then just to see whether those printouts of those guidelines are distributed in the district and facility level, and then, I don't know, do the random check of knowledge of healthcare workers by pre and post test after training and see whether they have taken the knowledge from that training. We talked about the fidelity audit, and feedback is a way to measure this in the past and in the future. And about the maintenance, just strategic plan, funding available, documented site visits, stock of consumables and drugs can be checked. Also the availability of diagnostics. That's what I have in mind.
Yeah, really, really well stated. And I mean, I think you're kind of highlighting how this strengthening of the surveillance system, and if I'm understanding you correctly, I mean, one of the challenges in many countries to looking at TB data and acting on it is that it's all aggregated. So you don't have individual patient data, which allows you to look at different strata. You know, until a few years ago, WHO didn't even stratify data by, you know, age or gender. And so it was really hard to see these disparities. But once you have a system like that, it can be very powerful. Even getting metadata, like I'm wondering whether, you know, there would be information on which provider was managing you, because you could then look at
there is this information.
Provider level
yes,
adoption, right? You could see, are there differences in the uptake? And you know, one of a powerful idea in implementation science is when you find differences, they're often interesting to explore in terms of, you know, do those differences lead to different outcomes, or what are the reasons behind them? And sometimes, you know, there's a quality problem when you see differences, let's say across clinics or across providers in terms of adherence to practices. Other questions from the audience? How are we doing on time? Yes.
Thank you. I kind of have a similar question regarding next generation sequencing. Do you think that the success of the treatment will improve if you start next generation sequencing? I mean, the deeper molecular surveillance in between individuals, and are going to do that?
Well, next generation, actually, we do have one project which we are doing in collaboration with KNCV. It's called No Pandemic Project, and it does a qualitative research. We have, I think she's here. Okay, she will be master's. She's doing master's thesis on that. She needs to do the. It's a long answer. Do I have time for that, or should I just? Okay. So, and she's gonna do the in-depth interviews with stakeholders to understand whether the next generation sequencing can be used as the not point of care test itself, but I mean, can be used on a routine basis to guide the treatment, and whether it will have an impact on the early diagnostic of drug resistance and a proper regimen prescription. for the patients. So we will see the results and we will see the perspectives. From my end, what I can say, next generation sequencing is very important in terms of monitoring development of drug resistance to new drugs, which are being right now rolled out worldwide, including this country, especially to monitor the resistance to protamine, to monitor resistance to bedaquiline. I don't know if it right away improves the outcome, because I don't know if it's going to shorten the time to treatment initiation, but it definitely would provide the epidemiological data, what drives TB infection, and where to target the interventions. That's how I see it with my limited knowledge of its use at this point. Yeah.
For now, rifamycin is the target, right? You mentioned the WHO rapid test. It's GeneXpert, as I know.
GeneXpert, yes.
Yeah, so it's for only rifamycin, right?
Not only rifamycin, there is also the Expert XDR, which does the resistance to fluoroquinolones as well, and it's used for differentiate whether to use B-PAL or B-PAL regimen. So, yeah, not only RIF.
Yeah, I mean, just to add a little context here for those that don't do TB work, this is a great example of a technology that everyone's excited about. So what it's doing is it's sequencing the MTB genome and giving us information about what is the likely resistance at the time of diagnosis. Whereas if you went back 10, 15 years ago, you wouldn't know this information, for 3 to 6 months in many programs, by which time people might already be resistant to additional drugs. So theoretically, it's a very exciting technology, but as with many diagnostics, there's a lot that happens between diagnosis and treatment outcome. And it's generally been very difficult to show that diagnostics improve treatment outcomes, despite the fact that they may be very important for many other reasons. So this example of a technology that's still kind of early stage, we have a lot of effectiveness questions, but we also have major implementation questions. And part of that is figuring out feasibility, acceptability, and also what's the appropriate use case and where can it have an impact. And so even at this early stage, implementation outcomes are very important. Irma, how are we on time? Okay. Yep. A little bit of time. So Lynn has another question.
Yeah, just a comment. I really liked your thought about using nominal group techniques. So something that you were introduced to, that's a very straightforward way of gathering people's perspectives as a potential strategy for trying to close one piece of the gap that you have, right? I mean, that's a really interesting and targeted way to use an implementation strategy. It's a great idea.
Thank you very much. Thanks for it.